Very interesting topic. Clearly, you've put a lot of work in this, and it looks like you've done what, is it over 500 cases? I think I heard you say.
It's almost 700 with different designs.
Got it. So
mainly two designs that we used.
Right, and so I'm not sure who's listening in have actually tried the mini stem, I guess you're calling, or the mini hip. But from your impression, can you give some insight as to the learning curve associated with this particular approach? Is there anything specific or unique before you get to that point? It seems to me that the intraoperative considerations, especially around an intraoperative periprosthetic fracture, would be the big risk here. And getting through that. I wonder if you have any insight around the number of cases or any research that you might be doing that might help understand that learning curve.
Yeah, first of all, you need to choose well the patient. I would recommend that the surgeon starts with a young patient with good cortices, a male one with a nice femoral neck. That's the perfect patient to start. Then I think it's mandatory to use the vascular clamp because that gives you a lot of sensation of the femoral canal, because you are used to go straight, and using this type of stems, you need to go curved. So you use the vascular clamp and you start coming the endomedular fat or products. And that's because you are right. In the case you are in doubt, you can use the image intensifier. And I learned the technique with a German surgeon who had 800 cases when I was there in 2010, and he used the image intensifier in every case. We don't use it, but if you are in doubt, it's better to put the image intensifier. And we have a cortical femoral perforation in case number 6. It was a girl, a very young patient, 19 years old, with idiopathic chondrolysis. We made a one-stage bilateral. On the right side, we put a short stem, no problem. On the left side, we also put a short stem, and when we observed the postoperative X-ray, we had a femoral perforation of the cortical, and we had to remove that stem, of course, and use a conventional one. So the learning curve, I think I may say that it's about 20 to 30 cases if you're a hip surgeon. It's completely different as if you need to start with a resurfacing arthroplasty. Before we started with this, we have been using resurfacing arthroplasty for maybe 10 years, and not too many cases, but if you have to perform a resurfacing arthroplasty, I remember that I couldn't sleep the night before, and this is much easier. And if it is much easier, it is better for the patient, I think, because you will have better results. And I think anybody can use it. It's not a property of the hip surgeon. I think this could be used by all orthopedic surgeons.
Great point. There was a question here from Diego. Diego, do you want to come on video and just ask the question directly to Professor Buttaro? It's about the backup in complicated cases. I think it was Diego who had sent the message. Yeah, he's coming on video now, I think.
Diego, do you have also long stems and second choice in case of complications? Yes, not long stems, but conventional ones. We always have a conventional stem when we use a short stem. Even though 10 years have passed since the first case, we do have, for example, every time we use an uncemented conventional stem, we have a cemented one also. Yeah. And I think that's mandatory. Because something can happen, and if you don't have it in the operating room, you have to wait until they bring it to you, and that can, you may wait 1 hour or 2 hours with the patient in the operating room. So every time you use an uncemented stem, you have to be a cemented stem. And every time you use a short stem, you have to be a conventional stem in the operating room. Sometimes you realize, especially in ladies or in young patients, female patients, that the bone quality is not good, and you change inside the operating room to a conventional stem. So that's a good question.
Is there anyone else have a question you'd like to ask the prof? If not, I can happily continue my conversation with you, Martin. The one thing I would like to ask for anyone who's listening in and has access to video as well, it looks like half of you have actually tried the mini stem or the short stem. I would love to hear from you about, what the experience has been in terms of your learning curve and your general satisfaction with the approach. But while we're waiting for some of you to maybe provide some of those comments, one of the issues, your last slide, Martin, which is probably one of the critical slides in a way, which was the issue of, well, in theory, a revision after this procedure should be much easier. You've given a long, strong rationale. It's a bone-preserving procedure, and you don't have a lot of. I guess there hasn't been a lot of experience at this point with the secondary procedures that may happen, over time. Do you have a sense, in your impression, how long this hip should last? I know you've got a pretty good 10-year outcome. What do you think about this hip compared to conventional hips? And also, what do you think about the reality of having to do revisions and the ease of doing revisions with this particular approach over other approaches, especially in the young active patient?
Well, let me tell you what happened to me twice. Sure. Once I told you, and the other one I show you. Sure. The first one I have to revise the same day I put short stem, so it was, of course, loose. And the second one, it was also loose because it was this orthopedic resident who had this short-term failure. So the stem went out very easy. And what I think is that if the stem is loose, you will remove it very easily. The problem could be if there is an infection with a fixed stem. And that is the same for an uncemented stem, or even more difficult because you have more area of fixation, or also a cemented stem. So I don't know how long will these stems last, but I think they will last the same as any conventional stem, because they are bone loading, they are loading the proximal femur. There is no stress shielding, at least with the two designs that we tried. For example, one of the designs has an ODEP 15 and the other one has an ODEP 10. So they have surpassed the 10 and 15-year follow-up with the same results as conventional stems. So maybe 10 years ago, it was not easy to know what could happen, but maybe, Mohit, in your career, you have felt, or you have, it happened to you that you felt an implant or anything in orthopedics will definitely work, but there was no evidence in the literature. And as we are in an ortho evidence Zoom, and maybe this happened to you. You start with something and you change something in your practice because you are convinced that this will work, but there is no evidence. How would you do with this? Deal with this?
In fact, to very truthful, we just had a session before, right? An hour before, we looked with Professor Kanduja, right, from Cambridge, and we were talking about femoral acetabular impingement, and that and the 3 decades ago there was an idea, and then it's really ramped up. And in fact, we talked about the fact that the randomized clinical trial, while very powerful, may actually not be the right thing to do when something is being rapidly innovated. So collecting data as you are, I think, is the real important part of this equation, and presenting your data honestly and with integrity, I think, is what we have to do. We have to, I think many of us have to try it. and then also add to that overall database, Martin. So, I mean, this is to me is exactly that issue, right? Is that
Yeah.
exact question?
And what do you learn? Because in FAI, Professor Kandusha told us that there is 460 publications
right.
to read.
Yeah.
So, and of course, it would take too long to do a randomized controlled trial to demonstrate that a certain prosthesis is really better or similar than the other one. No? Because imagine after 10, 15 years, you find that both implants work the same, work well. How do you know that a short stem can be revised with a conventional stem? Because you will have too low number of failures. So it's not easy to.
No, fully agree. And I see. Sure. I mean, I see Dr. Kandusha right here. So please chime in, Vikas. Give us your insights here. Thanks for joining.
Apologies, I probably missed the beginning of the talk, Martin, but I don't know whether you've covered this, but have you done RSA studies, and what is the RSA looking like on these short stems?
No, we didn't do any RSA study. There are RSA studies in the literature from UK, from an author called T-O-H, but not us.
Okay. So that at least from the arthroplasty point of view, that is a good surrogate marker in terms of long-term outcomes. If you've got RSA studies, it gives you some confidence that this implant is actually going to last and not going to fail quickly.
Yeah, but maybe, well, there is evidence. I told before, I don't know if you heard, but the ODEP 10 of the mini hip or the ODEP 15 of the Meta. So I think that's a proof of that they work. When I started 10 years ago, everybody said, well, why are you using this? You don't have any evidence. But as I previously told Professor Bandari, you sometimes have the feeling that something is going to work well, and you start with it without evidence. It happened to you, I think.
And I guess the question. Oh, go ahead, Vikas. Go ahead.
No, I was saying the best way to stifle innovation is have parameters where you can't do anything else and only use ODEP 10. If you need innovation, then you just need to make sure that it's controlled innovation, and you're monitoring your activity and monitoring your outcomes as well.
Yeah, I fully agree. Sure. I mean, just from a question, at what point for you, Martin, did you realize? Because now you've done 700 of these procedures, or more than 700. At what point did you realize this is going to have tremendous value? Because before you do your first case, you have a belief. You strongly believe that it makes sense. At what point did you realize this is absolutely, for me, a big part of my tool, my armamentarium, a solution that I will be offering patients, that young active patient?
I realized after 50 cases, but remember that we were coming from the resurfacing arthroplasty. We were using some special design that was removed from the market due to a problem in the cap, and I didn't want to use metal on metal. So I was not happy for the young patients to use that surface bearing. So when this happened, I thought it was something in the middle, something like it was more or less the same that I was used to do, and with the same surface that I used to do, and just like a little bit shorter with the preservation of the neck. So that was really seductive for me.
Superb. There's a question here from Carlos. I don't know, Carlos, if you feel you can come on video and ask the question directly to Professor Buttaro. If not, we can certainly, you can see it in the chat box there, Martin, about the age of the population.
The age of the population requiring total hip is increasing. What do you think about the advantages of a short cemented femoral stem? I never used short stems in aged people. I always indicate between 55 and some 60-year-old patients who practice sports. I don't see any indication for cemented short stems. The only indication I see is maybe thinking about femoral neck fracture, for example, if you don't want to make an invasion of the diaphysis, more invasion of the diaphysis, because this could be related to bone cement implantation syndrome. So maybe that could be useful, but not for using less bone, because if it is an old patient with an Exeter type stem, that will work great for 50 or more years. So I don't see this. There may be an indication for short stems, cemented or uncemented, in all patients.
You also raised the point, Martin, and you just mentioned it. It was going to be one of my questions: is have you used this in patients with femoral neck fractures, and if so, what's been your experience?
No, I don't know. There are some papers using this in femoral neck fractures because they say it's less invasive, but I don't think so. The approach is the same. Maybe you do not invade the diaphysis too much, but there is no data that it's really a benefit. And at least in Argentina, this type of implants are more expensive than the conventional cemented ones, of course.
Right, right. Any other questions from anybody? I don't want to monopolize, but I have one more question maybe. Looks like there's a question from Michael. Yeah, please come on screen and ask.
Hi, Dr. Buttaro. Thank you very much.
Hi, Michael.
Hi. I just had a question. Obviously, we're changing the mechanics at the hip joint a little bit with this type of an implant. And I was curious if you have any thoughts or have looked at all about the forces that are happening about the articulation, and what type of bearing surface are you using for the majority of your cases?
Thank you. Good question. The majority of our cases, we are using now ceramic on polyethylene. We started with ceramic, a lot of cases of ceramic on ceramic, the delta ceramic. We observed some squeakings, and also due to a cost issue, we now use ceramic on poly. Maybe in a 20-year-old patient, we use ceramic on ceramic. And concerning biomechanics, we didn't do any own study, but there are some studies from the Pipino in the 90s and also from Freeman that studied the biomechanical bone load in short stems preserving part or all the femoral neck. So these are good studies that are from 30 or 40 years ago.
Thank you, Martin. Vikas, you had a comment or a question maybe.
One quick question. What's your standard head size, Martin?
Standard?
Head size for these
head
patients?
Size, 36 from 54 and up, and 32 from 52 and down.
Okay, thank you.
Thank you.
So Martin, I think just before closing here, if you were now there, half the people who have who are listening in tonight have used it. So I believe they have their own beliefs. For the other half who haven't tried it, what would be your, I'd say, pitch in a way? And I think you've given a lovely presentation, but what would be your closing argument for the 50% or so that haven't tried the mini hip or a short stem to give it a consideration?
Well, if you want to do a more bone preserving surgery in a young patient, you may offer this to the patient because it works. There is data, 15 years, 10 years, it's published, no randomized controlled trials, but there is data. I think there is one randomized controlled trial, but with a design that is out of the market. But I think that thinking about the patient in 20, 25, 30 years, if that stem gets loose, you can remove it and use it a conventional one. So that may be the main reason. Not to outperform the conventional stems, just to do the same, have the same result, but with less bone consumption.
Wonderful. Thank you very much. Thank you all for attending. And we look forward to further interaction and learning more about the data as it comes up for this interesting procedure. Thanks again, everyone. Have a wonderful evening.